Good afternoon. I'm Amanda Kramer, Director of Provider Education for the Association of Community Cancer Centers. I'm excited to kick off our first webinar for the Institute of Clinical Immuno-oncology, also known as ICLIO today, with a riveting presentation by the ICLIO Advisory Committee Chair, Dr. Lee Schwartzberg, on the immune-related response criteria, variations in immuno-oncology response patterns, and implications for treatment. In addition to today's webinar, the ICLIO e-course series will feature 11 free webinars presented by cancer immunotherapy experts and will cover 5 domain areas: clinical optimization, management best practices, coverage and reimbursement, patient access and advocacy, and training and advancement. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by IO, and includes other vital resources such as newsletters, papers, scholars program, and a national conference scheduled for October 2nd in Philadelphia. Following today's webinar, I hope you will visit www.accc-iclio.org. That's www.accc-iclio.org to browse all of our offerings. This presentation will be archived and available on the ICLIO website by the end of the week. For today's live webinar, if you'll notice, there is a text box at the lower right hand of your screen where you are able to submit questions throughout Dr. Schwartzberg's presentation. When you hit submit, only the organizer will see your question, and she will then feed them to Dr. Schwartzberg at the end of his presentation for response. Now, for today's e-course. I am pleased to introduce our presenter and ICLIO Advisory Committee Chair, Dr. Lee Schwartzberg, Medical Director of the West Clinic and Chief Division of Hematology Oncology and Professor of Medicine at the University of Tennessee. Additionally, he was the founding Editor-in-Chief of the journal Community Oncology and the website oncologystat.com, and serves on the editorial board of the Journal of Supportive Oncology. Dr. Schwartzberg's major research interests are new therapeutic approaches to breast cancer, targeted therapy, and supportive care. He has authored over 110 research papers and maintains a private practice in medical oncology focusing on breast cancer. He has also been a champion for IO initiatives and implementation. Thank you, and Dr. Schwartzberg, please take it away.
Thank you very much, Amanda. It is my great pleasure and privilege to be the inaugural presenter for this series of webinars on immuno-oncology. And I'm very excited about the Institute for Clinical Immuno-oncology because, as everyone knows who's on the call, this is one of the most exciting times that I can remember in practicing medical oncology, as we have these new opportunities with several and soon to be a host of new immuno-oncology agents that have shown fairly remarkable activity across a wide range of cancers. And this is changing the way we're thinking about treating our patients across many different types of diseases. The promise of immuno-oncology also brings with it some challenges, and these are the challenges that we hope to address successfully with the ICLIO initiative. And you heard about many of the different domains that we're going to be working on through these webinars and also through meetings and print pieces and many other ways to get the information out to everyone that needs it. So we're going to start today with one of the areas that may not be as familiar, to understand why RECIST criteria have been adapted in assessing tumor response to immuno-oncologic agents, to understand the differences between RECIST and immune-related response criteria, which are now called irRC, the immune-related response criteria, understand how irRC's use in evaluating tumor response to immuno-oncologic agents, and to understand the diversity of potential tumor responses to IO agents and the direction of treatment planning in the practice setting. So let's start by reviewing how we currently evaluate patients, and that is the imaging and clinical program called RECIST, or Response Evaluation Criteria in Solid Tumors. This has actually a long history, which I won't belabor, but basically the RECIST criteria were first published in 2000, and this brought some clarity to the way that particularly clinical trials were assessed for responses. And of course, we know for many years now that responses in terms of tumor shrinkage on imaging or by clinical criteria or by tumor markers predict to a lesser or greater extent to the outcome of how patients will do, outcomes being progressive-free survival and overall survival. And we needed a measurement system to allow us to all speak the same language. That started with the WHO classification, which is quite old, and new criteria were developed about 15 years ago, the RECIST 1.0 criteria, that very specifically tells how to evaluate and puts actual criteria around what constitutes stable disease, progressive disease, complete response, and partial response. This was updated in 2009 with RECIST 1.1, which made it a little simpler to do this kind of exercise in a clinical trial setting. While RECIST criteria are not used in the as an analytic tool in clinical practice, I think it's fair to say that most clinicians actually do the same estimations when they're reviewing scans and to see the progress of their patients and to characterize them as having a response or not. So RECIST allows the clinicians to determine who's responding to therapy and whether or not their disease has progressed. So here are the RECIST 1.1 criteria, and I'll just go through them very quickly. There are a number of target lesions that are identified across a particular imaging modality, most typically CT scans, but could also include PET scans and MRIs. And basically, RECIST 1.1 simplified it, looks at 2 target lesions per organ, 5 lesions total. And these are lesions that are measurable. And I won't go into the measurements in detail, although it does look at the sum of the perpendicular diameters of these target lesions. And as everyone knows, a complete response means that every imaging, the imaging technique shows no evidence of disease. All the lesions that are target lesions and non-target lesions have disappeared. A PR is defined by RECIST 1.1 as a 30% decrease from the start of baseline of the extent of disease, and it has to be confirmed. Progressive disease refers to a 20% increase in the sum of diameters, and stable disease is when you don't have a partial response, in other words, less than 30% decrease, and in the range up to less than 20% increase. RECIST also looks at non-target lesions, which can be lesions that are not measurable, or other lesions, and as noted here in that slide. A measurable lesion is defined as being at least 10 millimeters in the longest diameter by CT scan, or 20 millimeters in the longest diameter by X-ray. The time point of response is shown here, and I won't go into detail on RECIST 1.1 except to make a couple of points. First of all, typically we evaluate tumors every 6 to 8 to sometimes 12 weeks after the initiation of a specific therapy. And that, of course, in general is to give the tumor time to respond to the therapy and to get in an adequate amount of therapy so that you can see the actual response. And there's actually a lot of work going on now about whether early responses to therapy predict for long-term outcome. That's still very early work, but it just shows the power of RECIST and looking at responses at intervals. You do need repetitive tumor evaluations to determine whether or not the response that you see is by the RECIST criteria a response that lasts. And that would include repeating a scan at least 4 weeks after the determination of a partial response or a clinical response to make sure that it's durable, in which case it would be considered a response by the RECIST criteria. Now, a very important point is the fact that RECIST was developed for determining tumor response to the kinds of therapies that we have used traditionally in oncology. And those agents are cytotoxic agents. As you know, cytotoxic agents directly kill tumor cells, or they can prevent tumor cells from dividing or increase apoptosis. So there's a direct effect on the tumor cell. Therefore, the response to a cytotoxic agent can be measured from the start of therapy by seeing what the size of the lesion is. And the assumption is that cytotoxic therapy is directly killing tumor cells. If one sees an early increase in the tumor burden or an early increase in the tumor size, so new lesions or growth in the size of the tumors that can be measured, that typically signifies progressive disease. And our standard paradigm up until now with cytotoxic therapy is when progression is detected, we stop using that particular agent or combination of agents and move on to another therapy because the growth of a tumor or the appearance of new lesions suggests that the tumor is resistant to that particular therapy. Conversely, a response after initial treatment of a cytotoxic agent can be used in many different tumor types to predict remission, progression, and survival. We're now in an era of immuno-oncology, and immuno-oncology agents differ from cytotoxic agents because they don't directly attack the tumor. Instead, they stimulate the immune system, the innate immune system, or the adaptive immune system of the host, the patient who has the tumor, and causes a secondary phenomenon by which the immune system attacks the tumor. And in this case, successfully attacks the tumor, hopefully, and kills the cancer cells through the immune system as opposed to a direct effect of the agent that is used. There are many different types of immuno-oncologic agents. Vaccines trigger the immune system to initiate an anti-tumor response against an existing cancer, and vaccines are a very broad term that can include many different antigens that stimulates the immune system. We have monoclonal antibodies. We have different types of monoclonal antibodies. Some monoclonal antibodies are directed directly against a tumor cell or a particular protein receptor on a tumor cell. They can block signaling pathways needed for tumor growth, and one example of that is the monoclonal antibody trastuzumab that blocks signaling in HER2-positive patients, and can also trigger an immune-mediated cytotoxic response, which is a secondary effect. And many monoclonal antibodies that target tumor cells actually work in through multiple pathways in multiple ways. More recently, we have the checkpoint inhibitors, which have generated a great deal of excitement. And checkpoint inhibitors work because tumors escape detection by the immune system. We know actually that the immune system is constantly in immunosurveillance of new tumors that are presumably developing in many of us all the time, but the immune system is able to clear the body of most of them because that is the function of any foreign antigen, including cancer-related antigens or cells. The immune system should work. However, cancer cells have adapted to our immune systems, and they can express checkpoint proteins which turn off the immune system. When it should be killing cancer cells, it doesn't. And some of those checkpoints are the CTLA-4 and the PD-1 receptors. Now, what we've learned over the last couple of years is that targeted inhibition of these receptors can then, if you will, remove the foot from the brake and remove the brake that the tumor engenders on these checkpoints and enhance the T-cell response towards the tumor. And we have also, for quite some long time now, used cytokines. And the cytokines that have been in use for now 30 years are the interferons, including interferon alpha, and some of the interleukins, including interleukin-2. These two agents, among others, have pleiotropic, very broad effects on the immune system. They simulate many characteristics of the immune system. And occasionally, these older agents will lead to a spectacular result of tumor regression. But because they're so nonspecific, they have many toxicities. And today in immuno-oncology, I think it's fair to say we're looking at more, as we understand the biology better, we're looking at more specific targeted agents like the checkpoint inhibitors. Because immuno-oncology agents work differently, the RECIST criteria I described may not be the most appropriate way to assess the tumor response in an individual patient. And the reason that RECIST may not provide a complete assessment is that, first of all, the anti-tumor response to immunotherapy from a temporal aspect may be very different than cytotoxic therapy. We sometimes see it take much longer for a response to generate than we do with cytotoxic therapy, and that's not entirely surprising since we have to go through many steps of stimulating the immune system, in some cases making new T cells, making new effector cells, and then going to the tumor, those cells going to the tumor and fighting the cancer. The clinical response to immune therapies can manifest after what we would normally call progression disease, and this is a very important point. The term has been created, pseudo-progression, and what this means, and I will show you some real-life examples of this at the end of this presentation, drawn from my own practice, that scans can get worse before they get better. And in the absence of clinical progression from the patient's, how the patient feels, and other aspects that are up to the clinician at this point to determine, there may be a disconnect between what the scan shows and what the patient is telling us about the way they feel. So this is a very important point to look for pseudo-progression, something that I think it's fair to say we almost never saw, or virtually never saw, in the era of using cytotoxic therapy. Because of these issues, it may not be appropriate to discontinue immune therapy unless a clear-cut progression of disease is confirmed. And that usually takes some extra time after one scan might show pseudo-progression or even some new lesions, as we'll see. So clinically insignificant progressive disease, that is the appearance of new lesions when other lesions are either responding or stable, should be considered, that is not an indication to stop an immune therapy in all cases. Also very importantly, we have seen now through investigations of all of these agents, including dating back to the era where we use cytokines, that stable disease can be a meaningful and long-lasting benefit for patients. That typically is not the case for cytotoxic therapy, but you can imagine that the immune system can work in such a way that while it might not always have a cytotoxic effect on the cancer, it could keep the cancer in check and keep it from growing. And in a patient who remains asymptomatic, a stable disease is clearly associated with clinical benefit. So because immune therapy works differently, we have to start to think differently in the way we're approaching our patients. And we have to think differently in the way we evaluate our patients with regard to the criteria. And this is just one cartoon that shows you why you might see pseudo-progression. So the blue cells are the cancer cells. The purple cells are the lymphocytes. And there's always some lymphocytes in a cancer deposit. If we give tumor immunotherapy, we often see a lot of lymphocytes come into the lesion. And in this particular case, you see the cancer cells were killed. So the overall lesion, and you can't distinguish this obviously on an imaging technique, looks smaller. And in this case, you would see a response by traditional WHO or RECIST criteria. However, you might see progression of disease. The immunotherapy might not work. And as you see in this example, in the middle, you're seeing many more cancer cells, and the lymphocytes are really not doing anything. So this is true progression. But the bottom panel shows you what would be considered progression by RECIST criteria and what we would now call pseudo-progression. So why do lesions get bigger? Well, if you see here, we actually have less cancer cells. But what's happened is the immune system has been so turned on that we see a dense infiltrate of lymphocytes. So the entire lesion has actually grown. We cannot distinguish the types of cells by an imaging technique currently. And so this would be considered by RECIST or WHO criteria progression, in which case the immune therapy might be erroneously terminated prematurely. And this has led to the development of the immune response criteria. Now, this was developed looking at the first of the checkpoint inhibitors that was approved by the FDA, which is ipilimumab. Ipilimumab is a human monoclonal antibody that binds to the cytotoxic T lymphocyte-associated antigen 4, or CTLA-4, on T cells. Blocking CTLA-4 from interacting with its ligand augments the T cell immune response to tumor cells, and this is an example of taking the brake off. Ipilimumab is indicated for the treatment of unresectable or metastatic melanoma, and it was studied initially in 3 multi-center phase 2 trials evaluating 487 patients with unresectable stage 3 or stage 4 melanoma. These patients were then categorized in terms of the activity of ipilimumab on the tumor using a novel set of criteria. The tumor assessments were carried out at week 12 following the end of the induction dosing period, which is the standard dosing of ipilimumab, 10 milligrams per kilogram every 3 weeks for 4 doses. And this was published in Clinical Cancer Research by Judd Wolchok in 2009. So what the investigators observed were 4 distinct patterns of response for patients with melanoma treated with ipilimumab. Overall, 30% of patients had disease control. That included a CR, a PR, or a stable disease, which is the standard definition of disease control. Of the patients who had response, 2 of the patterns met the traditional conventional criteria for tumor response. In the panel on the left here, you can see the triangles are the doses given of the ipilimumab, and here is the sum of the perpendicular diameters, typical RECIST criteria technique at time 0. So this is the baseline tumor burden as you see here. And this is an example of what we would like to see and what we typically do see when cytotoxic therapy, or in this case immunotherapy, works well. At the first time of evaluation, there was actually a complete response. And as you can see, this patient enjoyed a complete response lasting out at least over 150 days during those determinations by imaging. The second pattern is a stable pattern with slow, steady decline in total tumor volume. So here, the patient had his baseline tumor burden, actually went up a little bit at the determination at day 63 after the first 4 doses, the induction with ipilimumab, but it's less than the criteria that one would use for RECIST, so it would still make stable disease. And then what you saw was a very slow pattern to meet the criteria of partial response. That took quite some time, almost 6 months to get to that point, or over 6 months to get to that point, even though there was some decrease. So this is not a typical pattern that we see. We occasionally see this with cytotoxic therapy, but this is that pattern of a slow, steady decline in total tumor volume until getting to a partial response. The other 2 response patterns that were observed during this study were different than what we see in RECIST criteria. The first one on the left-hand panel was a response after an initial increase in total tumor burden. So here's the patient with their baseline tumor burden. They got 3 doses of ipilimumab, and lo and behold, their total tumor burden actually increased 100%. The patient remained on study and actually was observed after therapy, and 3 months later, the patient had achieved a 75% reduction in the tumor burden. So if the patient had not continued on observation here and continued on study, the study would have been deemed a failure here because of this large increase in the tumor burden. But this represented pseudo-progression in this group of patients. And this patient actually, with further follow-up, these group of patients with further follow-up actually achieved, in this case, a very good partial response. The 4th pattern seen through this study was a reduction in total tumor burden during or after the appearance of new lesions. So as shown here in this curve, the patient started with the burden here, and these are the existing lesions in the top line. The top line stayed essentially stable during the first imaging and then slowly declined. But there were new lesions that appeared and at day 63. And although the total burden, this blue line represents this is the total tumor burden on top, and this is the existing in blue line. And then new lesions occurred. So again, by traditional RECIST criteria, patients who had new lesions appear at the time of their first imaging would have been declared a failure. particularly as the total tumor burden was stable over time. So, however, these group of patients remained on study, and as you can see, they got additional doses in this particular trial, and the patients achieved a good partial response to therapy that took quite some time, over 6 months, to manifest and to plateau. So the appearance of new lesions did not necessarily mean that the patients were failing the immunotherapy based on using ipilimumab in metastatic melanoma. Here is a waterfall plot of these patients, which shows you the degree of response across the entire study. And as you know, in a waterfall plot, the patients who are each represented as an individual vertical line, either their best response was either growth, which is this group here on the left, or shrinkage of the tumor down to a complete response, which is represented here as 100% reduction in the size of the total tumor burden. What's important here, and I hope you can see this on the slide, is that there are little stars next to many of the patients who achieved, some of the patients even who had some progression of disease as their best response, but many of the patients who would not be considered a partial responder. And these are patients who had less than a 30% reduction in their disease, and they would be considered stable disease at best. In fact, 22 patients were characterized by the new criteria, which I'll show you, as an immune response partial responder or as an immune response stable disease, who would otherwise have been labeled progressive disease by traditional WHO criteria, and they're listed here. So the fact that we have a new criteria looking at the immune response is good, but does it represent anything in terms of the overall benefit to the patient? And the overall benefit to the patient is not, of course, seeing a shrinkage of a response on a imaging test, but whether the patient has longer progression-free or overall survival. And in fact, as you see here from this study, the patients that had a complete response, partial response, or stable disease by traditional RECIST criteria are shown here. The group of patients that were specific, that didn't meet these criteria but did meet the immune response criteria for PR or stable disease, had a median overall survival that was the same as the patients who had RECIST criteria. And it was only the patients who had progressive disease by the immune response criteria that went on to have a poor outcome, therefore proving that the new system actually has clinical utility, because those patients that do not meet RECIST criteria for stable PR or CR, but do meet the immune response criteria for those characteristics, using the immune response criteria and RECIST 1.1 to measure tumor response, in this case with the anti-PD-1 antibody MK3475 or pembrolizumab. And this was a trial that looked at patients with melanoma who got pembrolizumab. 215 of 411 patients had a traditional response by RECIST and by the irRC. That was a CR, PR, or a stable disease. And 51 patients, however, had progressive disease by RECIST, but had stable disease or better by irRC. So that's 51 of 411 patients. And the authors concluded that conventional criteria such as RECIST may underestimate the benefit of MK3475 in approximately 10% or even a bit more of treated patients. So this is not a rare phenomenon, and it occurs across agents. I showed you the data with ipilimumab, a CTLA-4 antibody, and now there is data with the PD-1s as well. So this, to the question that we talked about a bit before, we're definitely seeing this across different agents. Next slide, please. So here are the differences between the WHO or the RECIST criteria and the irRC. A new measurable lesion by WHO or RECIST always represents progressive disease. When you're looking at the irRC, it's incorporated into the total tumor burden. And a new measurable lesion or even a non-measurable lesion does not define progression. If you do find a new lesion, you can't call it complete response by irRC, but it does not necessarily represent progressive disease. The non-index lesions, those lesions that are not measurable by traditional WHO or RECIST criteria, contribute to defining an irCR, and that's different from the WHO, where they define overall response. So basically, you can have new lesions. You can't have a CR by immune criteria unless everything is gone, but you can have stable disease or partial response even with a new non-index lesion. Next slide, please. So how do we use the irRC, basically? An irCR is complete disappearance of all lesions, and it has to be confirmed no less than 4 weeks from the date it was first documented. A PR is a decrease in the total tumor burden of 50% relative to the baseline, which again has to be confirmed by another imaging of the same type at least 4 weeks later. Stable disease are patients that don't meet the criteria for either CR or PR, but in the absence of progressive disease. And IR progressive disease, or PD, is an increase in the total tumor burden of 25% relative to the nadir. That was the minimum recorded tumor burden, which is confirmed by an assessment at least 4 weeks later. So those are the important points to keep in mind. So now for the next few minutes, I want to turn to 2 case studies that were drawn from my own practice. The first real-world case example is a 52-year-old man who actually was first diagnosed with a low-grade papillary cancer and was referred by his endocrinologist to Dr. Portnoy, one of our physicians at the West Clinic. Dr. Portnoy did an evaluation with a CT of the neck, which showed extensive lymphadenopathy and multiple pulmonary nodules, which was confirmed by PET-CT scan, and also showed multiple nodules in the lung, subcutaneous metastases in the chest wall below the axilla, an adrenal mass, a mass in the gluteus maximus, and bony lesions in the iliac bone and the right hip. The patient at this time actually had right hip pain, weight loss, and fatigue. To complicate matters even more, he was a Jehovah's Witness and had a low hemoglobin and a high creatinine. Next slide, please. The patient underwent a supraclavicular biopsy, which showed metastatic melanoma. It was BRAF, KIT, and HER2 wild type. The patient was treated with supportive care measures and radiation therapy to the right hip. The patient actually finally started ipilimumab after these supportive measures were taken care of and the radiation in March 2013, at which time there was already progression in an 8-week period from January 2013. And the next slide shows you the scans from that first imaging when the patient started ipilimumab. And you'll see that there's a large mediastinal lymph node here in the left upper panel. There is a large hilar nodal mass here in the right upper panel. You can see pulmonary metastases in the lower panel on the left. And using a lung window for the CT scan, you can see multiple pulmonary nodules on this particular cut. And please take my word that there were multiple nodules throughout both lungs. Next slide, please. So the patient received 4 cycles of ipilimumab at the standard dosing and 3-week interval. He tolerated it relatively well with some pruritus, some right upper quadrant pain, and mild diarrhea. He came back after the 4 cycles in May of 2013, and the quote from the note is, he feels the best he has in 6 months. His pain was much improved. His fatigue was better. However, his palpable disease was no better. Hemoglobin had improved substantially with supportive care. And he had repeat CT scans in June of 2013, which were reported as progression of disease in the pleura, the left hilar lymph nodes, and the adrenal tumor. Next slide, please. And here are the comparisons of the same cut through the CT during the March exam prior to ipilimumab and the June exam after the full dosing of ipilimumab. So if you look here, this is the image I already showed you, and here is the corresponding image 2.5 months later. You can see that this node had increased in size, and this node had increased in size in the left hilar area. And you can see here at a different cut that the measurement of that left hilar node was bigger. And and then this is the same The next cut on 3/8 versus 6/21, you can see the left hilar node is bigger as well. Next slide, please. Here is the pulmonary nodule, which has enlarged substantially, and you can now see another nodule in this field, which was probably here, and you can see that's enlarged substantially. There's a new small right pleural effusion. And looking at it, the lung windows, you can see that several of the lesions actually look stable. Maybe this one is actually a little bit smaller. This one looks smaller for sure. This one looks stable, but then there's this new lesion here and another lesion here, which we didn't see in March. So in this case, we had a combination of most lesions getting bigger, new lesions appearing. And in fact, in 2013, the clinician made the decision that the patient had progressed and started the patient on Temodor. The patient took 2 daily doses of Temodor, which, as you know, is an oral DTIC agent, and was admitted promptly to the local hospital with pneumonia. Was in the hospital for a couple of weeks, was deconditioned, didn't get back to the clinic until the end of July 2013. And interestingly, the patient's right axillary adenopathy was clearly smaller by measurement. That was palpable. And Dr. Portnoy raised the question of a delayed response to Yervoy. And in fact, he was clinically improved when he was seen in July and improved substantially clinically over the next couple of months, and had a PET-CT scan in October 2013 that was read as much improved, which I'll show you on the next slide. So now we're comparing the scans from 6/13 to 10/13. You can see a dramatic decrease in the size of the mediastinal lymph node. The left hilar node is virtually gone in this image, and you do see it here. In this image, it was also from 6 to 10/13. It had shrunk quite dramatically, and you can also see this mediastinal node is virtually resolved here with normal size mediastinal nodes in the 10/13 scan. Next slide, please. And here, again, comparing the lower images, you can see the pleural effusion almost completely resolved. This large nodule that had grown in June of 13 is now resolved, and the hilar mass is gone. And if you look at the multiple nodules that were seen in June of 2013, there is almost complete resolution. You can see a small residual nodule here. So this would be considered a very good partial response. Next slide, please. The patient has been observed since July of 2013, actually since May of 2013, that when he finished his 4 courses of ipilimumab, with the exception of those 2 days of Temodor. In April 2014, his CT scan showed no pulmonary nodules, sclerotic, meaning healing bone metastases, and no adrenal metastases. And the most recent scan, which was done 3 months ago, showed no evidence of active disease. Truly a pretty remarkable result in a patient that was quite sick and had other medical problems to 4 cycles of ipilimumab. The second case is a 66-year-old female who presented with nausea, cough, and a 40-pound weight loss. She was seen by my colleague, Dr. Summer, at the West Clinic. Again, in 2013, she had a CT scan which showed a right upper lobe mass, multiple nodules in the lungs, bilateral hilar and mediastinal lymph nodes, and ground glass opacities, which were confirmed by PET scan. She had a biopsy of the lung mass, which showed moderately differentiated adenocarcinoma with no actionable mutation. She was treated with carboplatin and pemetrexate for 4 cycles and had a good response of therapy, and a stable partial response achieved and continued through several months of maintenance pemetrexate. She had progression of disease in May of 2014 with new consolidation and a mass in the right upper lobe, and was symptomatically worse on chronic oxygen. She was started on second-line erlotinib after a molecular test. The Veristrat test showed a good molecular signature. However, by November of 2014, she had progression of disease in the lungs. So here is her baseline scan prior to immunotherapy in 2014, on the next slide, if you will. And that slide shows this large mass in slide 31, this large mass in the right upper lobe, and you can see satellite lesions here, somewhat lower, collapse of the right upper lobe, another nodule in the left lung, and if you look here on the lung windows, you can see not only the collapse and this other nodule, but you can see several other nodules, and again, these nodules were spread throughout both lungs and upper and lower lung fields. Next slide, please. The patient was evaluated for a trial we had at the West Clinic, the nivolumab trial, for patients who had advanced non-small cell, non-squamous cancers. The patient initiated the trial in November 2014. 1 week later, she was admitted to the hospital with increasing shortness of breath, nausea, and diarrhea, treated with aggressive pulmonary measures, oxygen, and antibiotics for VRE in her urine. She improved symptomatically and was able to resume nivolumab, and she was reevaluated after several cycles of nivolumab at the beginning of January 2015. And here you can see her scans before she started nivolumab and after several cycles, I think 4 or 5 cycles of nivolumab every 2 weeks. You can see that the mass is essentially stable. It did shrink some. It didn't meet RECIST criteria. So by RECIST criteria, it was stable. And if you look at the lower mass here, it actually appears to have grown a little bit, and that there's the appearance of a new lesion here, although it's a little bit indeterminate. So by RECIST criteria, one would have said this patient had progressed with the appearance of a new lesion and at least some growth in at least one of the lesions, although this lesion did look smaller. And then here are the other comparisons. Again, some of these are smaller. She continued on nivolumab every 2 weeks and symptomatically improved. She went back to work part-time and has received 14 cycles of nivolumab to date. She had a CT scan just a few days ago on July 6th, which showed an overall 70% reduction in tumor size. And I will show you those scans. Next slide, please. So here are her scans from July 6, 2015. These are the 4 representative images just from the July imaging. This is what's left of that upper lobe. There's no collapse of the tumor. There's no hilar mass. The satellite lesion is gone. These are blood vessels here. There's a little bit of atelectasis that you can still see in the lower lobe, and you can see a tiny nodule that now measures 5 by 3.7 millimeters in the left lung, and a little bit of atelectasis. This patient has had a very meaningful clinical response and imaging response. And again, if the irRC had not been utilized, this patient might well have gone off study and gone on to a therapy that would not likely have been as effective as nivolumab was for her. So in summary, immune-mediated drugs such as the CTLA-4 inhibitors and the PD-1 or the PD-L1 inhibitors are finding use in many cancer types, and we're very excited about their utility going forward. Immuno-oncology drugs work differently than traditional cytotoxics by stimulating the immune system. With immunotherapy, imaging studies may show initial worsening of lesions in terms of size, and you may even see new lesions during that first therapy evaluation. Therefore, a new response system, the irRC, was developed and is in use now for patients treated with immuno-oncology agents. Most importantly, in the absence of clinical progression, which is a judgment by the practitioner, pseudo-progression on scans should be strongly considered as the reason for the change in scans that may show new lesions at first evaluation or a growth in lesions that had previously been identified. And patients should be reevaluated carefully, and their immune therapy should not be prematurely discontinued. So I will stop there, and thank you all for your attention.
We appreciate a very engaging presentation that you just gave, and a thank you to our audience for participating. The archived version of this webinar will be available on the ICLIO website shortly, hopefully by the end of the week. And I hope that all of you will join us for our next webinar with Dr. Renata Martins from the Seattle Cancer Care Alliance, who will discuss the role of immunotherapy in non-small cell lung cancer on July 28th. That's at 11:30 a.m. Eastern Time. Please visit the ICLIO website. That's ACCC-ICLIO.org to register for that webinar. Have a great afternoon. Thank you.